Dr. Sarakbi, you can begin.
Okay, hello everyone, and welcome to this year VIB program. Let me introduce myself first. I'll be the moderator for this session. My name is Sam Sarakbi. I'm the program director for Adult Rheumatology Fellowship Program at Wayne State University, DMC in Detroit. My co-moderator will be our second-year fellow in the program, Dr. Dia Ubaidat. Both of us will be moderating this session and looking at your questions and ask Dr. Jonas about it. A few housekeeping items before I introduce Dr. Jonas. So the attendees are muted throughout the webinars. And number two, if you have a question, don't put it in the chat, put it like in the Q&A. So we'll be looking at those questions to ask Dr. Jonas in the end. And you can raise your hand to notify the host if you need attention. We may do like a private chat for the response. And that's it for the housekeeping. Now, it gives me pleasure actually to introduce Dr. Beth Jonas. She is the Rivas Foundation Distinguished Professor of Medicine and Chief of the Division of Rheumatology, Allergy, and Immunology at the University of North Carolina at Chapel Hill. Dr. Jonas received her medical degree from SUNY Upstate Medical Center and completed her residency in internal medicine at the George Washington University, where she also served as chief resident. She completed her fellowship training in rheumatology at Emory University. Dr. Jonas is a clinician, educator, and has an active rheumatology practice where she sees patients with a wide spectrum of inflammatory rheumatic conditions. She teaches rheumatology to medical students, residents, and fellows, and is actively involved in curricular development to train both physicians and advanced practice providers in rheumatology. Dr. Jonas was awarded the American College of Rheumatology Distinguished Fellowship Program Director Award in 2015. She has received Rheumatology Research Foundation and Clinician Scholar Educator Award. And without further ado, we'll let Dr. Jonas take over.
Good morning, Dr. Sarakbi, and all of the fellows and faculty joining us this morning. It is really my distinct pleasure to be with you. I am going to spend the next chunk of time talking about plain radiography for rheumatology fellows, and this is really going to be kind of a nuts and bolts lecture, and to sort of get you started on a learning to evaluate plain radiographs. Primarily, we're going to be looking at arthritis. So I have no disclosures. So here are our learning objectives this morning. First of all, I want you to develop a systematic approach to the interpretation of plain radiographs and the evaluation of arthritis. And I want to just focus on systematic approach. One of the things we're going to focus on really is to sort of do this the same way every time so that you don't miss things. I want you to be able to describe the plain radiographic features of the most common forms of arthritis, and we'll go over that. And I want you to be able to apply the knowledge that you learned to make a diagnosis of arthritis, and at the end we'll have some questions for you to answer. So there are lots of imaging modalities in rheumatology that you will need to be familiar with. We are going to focus primarily today on plain radiography. But I also want to point out that many of you, probably most of you, will be learning about ultrasound in your clinical practice. And I think this is a very important modality, but does not really replace plain radiographs in the evaluation and management of patients with primarily arthritis. MRI you're going to learn about, CT you're going to learn about, and now increasingly dual energy CT for the evaluation of crystal-induced arthritis. Plain radiographs, which we're going to focus on today, are really good for imaging of bone. They're relatively insensitive in early arthritis, but they're readily available in most offices and in most hospitals and can be very useful in monitoring disease progression in patients with arthritis. So one of the questions that comes to me all the time from new trainees are, which x-rays do I order? And I think this is a very important question. You want to tailor your ordering to your suspected clinical diagnosis. So for a patient with rheumatoid arthritis, obviously this is a disease, as we're learning, of peripheral joints, primarily hands and feet. So in patients with rheumatoid arthritis, that's generally what I measure. Having said that, if you have a patient that has another joint that may be very active, you may want to image another joint. So you're going to let your clinical evaluation guide that. If you're suspecting ankylosing spondylitis or any kind of axial spondyloarthropathy, you're going to want to look at the sacroiliac joints, plus or minus the spine, depending on the patient. And again, as you learn more about the different forms of arthritis, you're going to learn which joints are affected and which joints you're going to order. And you're going to tailor to the demonstrated pattern of joint involvement based on your history and physical. You do not need to image every single joint that's involved. You want to be very mindful about the radiation dose. You want to be mindful about the cost, and you want to think to yourself, what am I going to learn from that x-ray that is going to, number one, help me make a diagnosis, and number two, impact the care that I provide to that patient. So I give this to you as a reminder. It's very helpful to know your joints of your hands and wrists. You will be referring to these constantly as you are working up your patients. So I'm not going to go over all of this. Everyone has a mnemonic of how they measure this and how they remember this. But these are the bones of the hands. So radiographs of the hands are really most informative for screening patients with suspected arthritis. And as I mentioned, they may be useful in monitoring progression. And for example, in patients with rheumatoid arthritis who primarily have disease of the hands, you're going to be measuring their radiographs over time to, number one, look to see if there's erosive disease or other evidence of joint damage. And number two, to say, is the therapy that I've chosen for this patient, and which I think is working, really working? We recommend two views of the hands, the PA view and then the Norgard view, which is sometimes also called the You're in Good Hands with Allstate view. I don't know if that commercial is even still on TV, but anyway, this is the view. And what's nice about the Norgard view is that, as you can see in this picture, this is really the only view where you can see the pisiform bone. And the pisiform bone is on the volar aspect of the wrist, and it's really, you can't see it on the AP because it's of overlying shadows, but it may be involved very early in patients with rheumatoid arthritis. So that's what that view gives you. And they have to be really positioned correctly. So as you're looking at x-rays when you're first learning, it's really helpful to do this with a radiologist or a rheumatologist who is, really good at this, to know whether your radiographs are actually well positioned. Because if your radiographs are not well positioned, it's going to be hard to evaluate them. And as I mentioned when we started, a systematic approach is absolutely critical. You want to look at the radiographic changes in a specific joint, and then the distribution of these changes within the hands and wrists. And this can be really true of any joint. It can be the feet, the SI joints, the knees, or whatever. And so this is the systematic approach that I'm going to propose. First, I like to look at the soft tissues. Let me say that as a rheumatologist, we're always looking for erosive disease. And so your inclination is to go straight to erosions. And I just want to put in a plug for not doing that. Just step back and say, what can I see about the rest of what's going on in that film? Because if you start looking for erosions first, you're going to miss all these other very important things that could be helpful. And if erosions aren't there, then you're going to want to know what's going on in the other tissues. So first I look at soft tissue. Is there swelling? Is there calcification somewhere? Are there foreign objects? Yeah, sometimes there can be foreign objects in tissues, thorns or bullets or God knows what all else. You want to look at the alignment of the bones and the joints. This is really important to know what normal alignment is, and that's going to be one of your projects over the next weeks, is to really look at a lot of films and know what normal is. You're going to want to look at bone mineral density, and if the bone mineral density is abnormal, Is it abnormal in the periarticular regions around the joints, or is there diffuse osteopenia? Now, there are bone diseases that have increased bone mineral density. That's generally not something that we see in patients with arthritis, but that's something to think about also. I'm thinking about Paget's disease of bone and other things like that. But for arthritis, we're really looking at decreased bone mineral density. Then next, I look at the joint space and see if the joint space is narrowed, and whether that narrowing is uniform or non-uniform. Remember, what lives in the joint space? So the joint space is the place in between the bones, and this is cartilage and other soft tissue and the synovial space. And so we can tell a lot about what's going on in a joint by how compressed that joint space is, because that's basically a measure of how much cartilage loss there is in a patient with arthritis. And then finally, we're going to look at erosions, and we're going to want to know what's the location of the erosion, and are there other associated findings around that erosion or around that joint that's eroded that may help us make a diagnosis. So again, we're going to start around the joints, not in the joints. We're going to look for soft tissue swelling. We're going to look for subluxation and dislocation. We're going to look at mineralization of the bone, calcification around the joint or anywhere else in the structure, joint space narrowing, erosion, and then bony production. And we'll talk a little bit about all of these things as we work through this. So soft tissue swelling around a joint or a joint group may be symmetrical or asymmetrical. You may see fusiform swelling around a joint, so, just like a whole joint. And that digit that's swollen is often called dactylitis, which is just essentially swollen finger or swollen digit. You may see nodular soft tissue swelling or lumpy, bumpy swelling, which is characteristic of gout. So here are a couple of pictures just to orient you, and on the right-hand side, the left-hand side of your screen, you have normal, and on the right-hand side, you can see soft tissue swelling. And some of what I'm showing you here may be technique of the film, but here you really can't see the soft tissues, and here maybe slightly underpenetrated, but you just get the sensation that there's a lot of extra soft tissue, particularly around this third PIP, the second PIP. Now, you don't need a radiograph to tell you that someone's hands are swollen. Hopefully you've examined their hands in the clinic and you know that, but when someone's looking at the film who may not have looked at the patient, such as the radiologist, it's helpful for them to see that. So again, on the left-hand side of your screen, you see a normal hand, and on the right-hand side, and if you're sitting in a very bright room as I am, you can't really see this, but that index finger has diffuse swelling across the whole digit, around the DIP, around the PIP, and around the MCP, and this is dactylitis. And if you compare that to the next digit number 3, you can see that the soft tissue thickness is greater in the second digit than it is in the first digit. This is a patient with psoriatic arthritis. We're going to talk a little bit about the erosion, which I know your eye jumps right to, but what I want to just point out is that this digit is remarkably swollen compared to the one next to it, which is normal. So again, on the left-hand panel, a normal hand, and on the right-hand panel, you see multiple areas of soft tissue swelling that are sort of lumpy, bumpy. You see this here in the 5th digit. You can see it here at the wrist, even along the shaft here. And then in the 4th PIP, the 3rd PIP, and of course this really big one, which has, and we'll talk about an associated erosion next to it. This is a large tophaceous deposit in a patient with gout that gives you this very characteristic bumpy swelling in the soft tissues. Next, we're going to move to alignment and subluxation. So on the left, again, a normal hand, and on the right, you can see really profound ulnar deviation at the level of the MCP joint. And you can see, obviously this is deviated to the ulnar side of the hand, I will also caution you is that sometimes you'll see patients that have ulnar deviation when you evaluate them in the clinic. And because that may be, at least in the early stages, reducible, when they go down to radiology and the tech asks them to put their hand flat to take the image, these may straighten out if they're reducible. So don't be surprised that you see that. But now late in the course of disease in patients with, say, rheumatoid arthritis, or sometimes patients with lupus who have a Zickuhr's arthropathy, when this becomes more fixed, then the x-ray will look like this. So on this film, this is a patient with very advanced erosive rheumatoid arthritis, and there is subluxation and ulnar deviation at the level of the MCP joint, and you can see it in both hands on the left and then on the right. But I also want to point out that in this patient, there's radial deviation at the wrist, and people don't talk about this as much. They often talk a lot about ulnar deviation, and then you see sort of like the hand looks a little bit like a Z. But so ulnar deviation at the level of the MCP joints and radial deviation at the level of the wrist. And you can see also in this patient lots of loss of joint space and a number of other findings, which we will talk about subsequently. So I also just want to say a brief mention. We're not going to talk a lot today about the cervical spine, but the cervical spine is something that you may image in patients with rheumatoid arthritis or ankylosing spondylitis or other axial spondyloarthropathies or many other kinds of arthritis. And one of the things that we look for is C-spine subluxation in rheumatoid arthritis at the level of C1, C2. And you'll see that people will order views, inflection, and extension. And what we're looking for at that time is really whether there's translational instability at the level of the C1 and C2 articulation. And you can see here that this is your dens, which is part of C2, and the pre-dental space is widened in this view compared to an extension. And so this is just kind of shows you a little schematic. It's a little bit easier to understand it with these images, is that you have your atlas or C1 and then your axis or C2, and the dens comes off of C2 and articulates into the atlas at C1. And when you are looking for translational instability, you're looking at the distance between the anterior portion of the C1 ring and the dens, which is coming right up there through that C1 ring. And here we can see that in this projection, in this position, the atlantodens interval, or the pre-dental space as it's sometimes called, is increased. And so normal is less than 3 millimeters, and above that is abnormal. And the concern being is that you can have spinal cord compression if there is translational instability at the level of C1, C2, and this is something we need to be very cognizant in our patients with rheumatoid arthritis. So again, you have to look at a lot of films, and it's sort of beyond the scope of what we're going to talk about today, but I just wanted to mention that to you. If you have a patient going to the operating room who's going to be intubated and their neck is going to be hyperextended, you want to know if there's translational instability. That will help the anesthesiologist intubate that patient much more safely. Next, we're going to look at bone mineralization, and the overall mineralization is estimated by measuring the cortices of the metacarpal shaft here, and you can do this on the second or the third metacarpal shaft. And normal, it should be, the cortical distance should be 50% at least of the distance across that shaft. And if it's less than that, then we call that osteopenic. Now, I want to caution you, you cannot make a diagnosis of osteoporosis or really even clinical osteopenia when we're talking about metabolic bone disease based on a hand film, but it may give you a clue that the patient may have osteopenia or osteoporosis. And of course, in that case, you may want to measure a bone density scan, a DEXA scan. And we'll have a talk on osteoporosis later on in this series, But this is helpful when we're looking at patients with arthritis to look to see, because often decreasing bone mineralization can be a marker of systemic inflammation. And this osteopenia may be diffuse or it may be focal. So in this case, if we look at the third metacarpal shaft and you sort of look at this, you can see that the cortical bone is less than 50% of the distance across that shaft. And so this is diffuse osteopenia. On the right, we really have focal osteopenia, because if you look here at the MCP joints, these sort of appear blacker. There's less bone in that periarticular space. And you can see this in patients with early inflammatory arthritis who have not yet developed erosions. And this may be reversible. So in other words, you may see this in early arthritis, you treat the patient with whatever therapy you're going to treat them, and that bone mineral density can improve. So that's important. It's mediated by a number of important cytokines that are relevant in inflammatory arthritis: IL-6, IL-1, TNF. Next, we look at calcification. We want to look at soft tissue calcific masses. We want to look for chondrocalcinosis, which are calcium deposits in the cartilage. We want to look for calcification of tendons, and then calcified vascular structures. So there's lots of places in the musculoskeletal system where calcium may be found abnormally. Now, the urate crystals in gout are not radio-opaque, so you should not be able to see that. However, when the urate is deposited in soft tissues forming a tophus, calcium may be precipitated with the urate crystals to varying degrees. So in some cases, as in an X-ray I just showed you a few ago when I showed you that sort of lumpy, bumpy mass, in some cases the tophi can be radio-opaque and you can see them. But urate is not radio-opaque, but when it becomes calcified, it is. Calcium pyrophosphate, on the other hand, can deposit in hyaline and fibrous cartilage, producing the radiographic picture of calcified cartilage. So calcium pyrophosphate is radio-opaque, and you can see that in and around joints. Hydroxyapatite deposition may also appear as a calcified mass around the affected joint, and I'm going to show you some radiographs of that. So this is a patient on the left with a calcified tophus. So this is the second PIP joint, and you can see this sort of lumpy, bumpy mass, and then a sense that you can, that this looks, it's not quite the same Hounsfield units, if you will, of the soft tissues, which are more water-filled, but sort of closer to bone or sort of in between the bone. Don't miss over here, there's some swelling and also tremendous erosion of bone, but for the purposes of this, I'm just wanting to show you this calcified tophus. On the right, we're looking at chondrocalcinosis here, sort of calcium in the ulnar portion of the wrist. This is a very characteristic place to see chondrocalcinosis. And this is really in the area of the triangular fibrocartilage of the wrist. And so if you have a patient who may present with inflammatory arthritis of the hands, and you've got CPPD in your clinical differential diagnosis, and you see this, this can be very, very helpful. Particularly in older people who develop polyarticular hand arthritis. If you see this, it's very characteristic of CPPD. CPPD arthritis can look just like rheumatoid arthritis, and it's important to make that differential, and this is where your radiographs can be very helpful. If you're concerned about this, obviously you may want to do a synovial fluid analysis, but it's very hard to do that at the wrist and get CPPD crystals unless you've got a lot of synovitis. Both of these radiographs show you acute calcific periarthritis. So this is not in the joint, but it's around the joint. And in this case, you can see this calcified mass, which is actually sitting in the supraspinatus tendon, which comes here across the top of the shoulder and becomes part of the rotator cuff. It's characteristic, you can see it in the shoulder, and here you can see it, and if you're not looking careful, you might miss this little calcific mass. And patients with acute calcific periarthritis from hydroxyapatite may present just like an acute monoarthritis. So acute onset of pain, swelling, not usually redness, but sometimes redness in a single joint, may look like gout in the appropriate clinical setting, could look like CPPD, rarely confused with septic arthritis. It's not generally that inflammatory, but it can be. But it can happen in lots of places. I've seen it in the shoulder, in the foot, in the wrist, in the ankle. So here's a picture of a patient, and there's abnormal calcification primarily in the vascular structures. And you can see this here in the right hand, and it's easy, you can sort of follow some of the arterial structures throughout the hands. Sometimes this is called calciphylaxis. That often describes people who have vascular insufficiency and ulceration, but you know, these patients may have, we see this in patients with chronic renal disease, in patients with diffuse atherosclerotic disease, and the like, but be on the lookout for those kinds of things. This patient doesn't actually have arthritis, but just calcification in the vascular structures. So this is a patient who has systemic sclerosis and has very effusive and lots of calcium in the subcutaneous tissues. This can look like this, sort of lumpy, bumpy, and mass-like. This is actually the same patient, and you can see she's got it on her fingertips. She has it here in the basal thumb joint, across the wrist, and in the hand. And this has been actually very, very progressive. This can also be seen in the setting of dermatomyositis, usually in younger people, but we do see it in older people. Sometimes the calcium in systemic sclerosis looks a little bit more plate-like and not quite this lumpy bumpy, but it can look any old way, and important to understand that and know about that. Sometimes these calcific deposits can be really big and need to be removed surgically, although oftentimes they don't heal well after that. So be really judicious with your use of surgery for these kinds of calcific masses. This is a patient who presented with elbow pain, and this is synovial chondromatosis, not really a form of arthritis per se. And why this happens is really unclear, but there are abnormal rests of chondrocytes of cartilage that become calcified, and these can be painful. They can limit range of motion in a joint, and sometimes need to be surgically removed. I've seen it happen at the elbow, I've seen it in the knee, and it usually is in the larger joints, and this is synovial chondromatosis. It's generally not a diagnostic dilemma. You take the picture and that's what it looks like, but it may be the cause of joint pain. Next, we're going to talk about joint space narrowing. All arthropathies can cause loss of joint width to varying degrees and at different rates, and it is sometimes not predictable. And as I mentioned earlier, when we're looking at plain radiographs, we're not really looking at cartilage, we're looking at bone, and what's in between the bone is the cartilage. So that loss of joint width is really a surrogate marker for cartilage loss. When you're looking at an individual joint, the narrowing may be uniform, so across the whole joint, or may be non-uniform, affecting one or another side of the joint more than the other. And identifying whether the joint space narrowing is uniform or non-uniform can help you support a specific diagnosis. So on the left-hand side, we see a patient with DIP disease, and this is non-uniform joint space narrowing, and you can see one side of the joint is really pretty bone on bone, and the other still has some cartilage. And on the right-hand panel, this is a patient actually who has diffuse or uniform joint space narrowing. You know, if you look at a single joint, you know, really along the whole range of the joint, the cartilage uniformly squished or gone, and that's true really in all digits along the MCP compartment. So uniform joint space loss really across the whole joint width, and then non-uniform, one part of the joint being more narrowed than the other. In general, when you see uniform joint space narrowing, as we see on the right-hand panel, that's a sign that whatever got you there was probably an inflammatory process, such as rheumatoid arthritis or psoriatic arthritis, or maybe an axial spondyloarthropathy. And when you see non-uniform joint space narrowing, that's a sign that what got you there was osteoarthritis or traumatic or post-traumatic or something like that. Again, you know, it's a rule of thumb. Things are not always black and white. No pun intended there. Often there's nuance there, but that's can be very helpful. So this is a patient with rheumatoid arthritis, and you can see there's, you know, very characteristic uniform joint space loss in all of the MCP joints. You can see here at the level of the left wrist, there's actually distal radial ulnar joint disease. But this is uniform joint space narrowing. You can also appreciate a little bit of ulnar deviation, particularly on the right, and then subluxation of the MCP joint. So you don't see really any joint width here because the metacarpal shaft has sort of moved over the phalanx. So this is a patient with osteoarthritis of the knee, and you can see that the medial joint compartment, both on the right and the left, is more narrowed than the lateral joint compartment. So this is a patient with osteoarthritis, as opposed to this patient where the medial and lateral compartments are more uniformly narrowed, and this is a patient with rheumatoid arthritis. Sometimes this is a little bit tricky, and maybe I have a feeling these may not be the best examples. And I'll show you a couple more as we go forward. So uniform joint space narrowing, generally a sign that what got you there is an inflammatory arthritis. That's really the learning objective and the point of that. So this is a patient with osteoarthritis over a 7-year period of time. And as I mentioned a minute ago, there's high variability in terms of how rapidly someone is going to develop this degree of joint space narrowing. This may happen over 7 years, as it's happened here, but may be faster in some patients and slower in others. So here on the left panel, you can see relative preservation of both the lateral and medial joint space. Over 4 years, you can see compression medially and then the development of some new osteophytes. We didn't talk about abnormal bone yet, but we'll get to that. And then at 7 years, this patient is really bone on bone in the medial compartment, but the lateral compartment looks pretty good. And you may appreciate on the patient's physical exam that because of the narrowing of that joint width on the medial side, the patient may be developing a varus angulation at the knee and may have some abnormal or malalignment over time. So next we're going to look at the patterns of bony erosion, and this is really I think a very, very important thing for early learners and all of us to learn and remember. So bony erosion is the hallmark of an inflammatory arthropathy. And as I mentioned when we started, it's often the thing that gets us to order the film to start with. The location of the bony erosion and the characteristics of that erosion can help you make a diagnosis. And what I've listed here is really just some rules of thumb. Again, not hard and fast, but will help you when you're categorizing and thinking about patients. So juxta-articular erosion, so right next to the articulation, or sometimes called marginal erosions, are characteristic of rheumatoid arthritis. Central erosion, so sort of in the middle of the bone. Again, I'm going to show you some pictures here in a minute. Characteristic of osteoarthritis. Erosion that occurs a little bit more distal to the joint, so not right at the margin of the joint, but maybe a little bit along the shaft on one or another side of the joint, is seen in gout. Characteristically, those erosions may have an overhanging edge over time in patients with gout. Patients with psoriatic disease may have something called a pencil-in cup deformity, And you may hear your radiology colleagues describing that. I'm going to show you some pictures of that. And then the presence of new bone formation or periostitis is characteristic of the seronegative spondyloarthropathy, so axial spondyloarthritis, or the arthritis associated with psoriasis or inflammatory bowel disease. The rules are not hard and fast, but can be a helpful guide, and you're going to want to let your clinical judgment also guide you. What's going to separate you from your radiology colleagues is that you will have taken a history and done a physical exam, and you're going to come to that radiograph with a wealth of understanding and knowledge about your sort of differential diagnosis, and you're going to use all of that data plus what you see on your radiograph to distill down a diagnosis. I also want to mention here that as a rheumatologist, you should have as one of your goals to be as good as, if not better than, your radiology colleagues at reading x-rays for arthritis. I think even in some radiology circles, this is a bit of a dying art, since many of the radiology residents and fellows are really looking to do lots of sexy things like MRI and interventional kind of radiology, but reading plain radiographs for arthritis is going to be something that you're going to do every single day. It's going to affect your patients and your patient care. It's going to affect how you choose what agent to use to treat them. So I want you to take as one of your personal goals to get really good at this. You're going to look at your x-rays each time you're seeing a patient with inflammatory arthritis to see where they are in time. You're going to be comparing them to their old films and really educating your patients about what's going on in their x-rays, because it helps them understand the rationale for what you're doing. So your goal is to get really good at this. And I will tell you, I've been doing this a long time. It takes a long time. You're not going to do it in an hour. You're not going to do it in a month. You're probably not going to even do it in 2 years, but you just need to be looking at a lot of films to help you gain this skill. So this is an example of a patient with a central erosion, and you can see here this erosion sort of in the central part of the distal interphalangeal joint, and also the presence of these osteophytes. This is sometimes called the gull wing deformity. Excuse me. This is your little seagull here at the beach. I wish I was at the beach. And you can see the way it sort of makes that sort of seagull shape. Then you can see it here in multiple joints, multiple PIP joints, this sort of central erosion, and then osteophytes that come out from that. And this is very characteristic of erosive osteoarthritis. So here are some examples of juxta-articular or marginal erosions in the setting of rheumatoid arthritis. And you've got your little arrows here. So right at the edge of the bone where the synovium essentially inserts on the bone. And so remember what's happening pathophysiologically in rheumatoid arthritis, which we're going to learn about a little bit further on in the course of our VIP lecture series, is that you've got synovitis, inflammation of the synovium, the development of pannus, which is a localized tissue which erodes into bone, and that's essentially the radiographic correlate of synovitis and erosive disease. You see that here. You can see it here, very not subtle at all, and really across all of the MTP joints in the feet. So juxta-articular or marginal erosions. These x-rays demonstrate a patient who has erosive disease with an overhanging edge. And you can see that this erosion is a little bit further down the shaft. So here's a marginal erosion. This is probably a little bit confusing. So this erosion is occurring at the margin, although it's super big. We don't know if it started at the margin or somewhere else and then ate across it. But down here, very characteristic x-ray of a patient with gout and this sort of punched out lesion with an overhanging edge. And when you see that, that's pretty characteristic of gout. Here you can see an overhanging edge, and you even get the sensation here that you've got this lumpy, bumpy, maybe slightly calcified tophaceous mass in this first MTP. Also a very characteristic location to have gout and a gouty erosion. So this is an example of a pencil in cup deformity. And of course, this is not subtle. You can see it, and the arrows are here, but there's actually, you can see it sort of happening here where the more distal bone sort of has developed a cup, and the more proximal bone is sort of going up into it, and that's the pencil and cup. And you can see it here at the PIP, and this is seen in patients usually with psoriatic disease, so pencil and cup deformity. These patients can have a very aggressive, inflammatory, and erosive and destructive arthropathy. So we're going to look next at bony production, and this can take a number of different forms. You can see periosteal, new bone formation. This is new bone deposited along the shaft or of the phalanx or the metaphysis just behind an erosion. You may see bone formed at tendinous insertions or ligamentous insertion, and this is seen often in spondyloarthritis. You can see bony ankylosis, which is bridging of a joint, seen in diseases that aggressively destroy the cartilage of a joint. Bony ankylosis also fairly characteristic of the axial spondyloarthropathies. So here's an example, a couple of examples of periosteal new bone formation. Sometimes it looks like this sort of fluffy density along the shaft. You can see it on both sides, here and here. And again, on here. Here you see that there's sort of diffuse swelling, maybe even dactylitis, and this sort of fluffy new bone formation. Again, when you see that, you should be thinking in the setting of arthritis, you should be thinking about the axial spondyloarthropathies that may be affecting peripheral joints. You can see bony ankylosis in this case. So this is, an inflammatory arthritis, which is very destructive. Now, when you examine that patient, you probably already know that they cannot flex that finger, and that may be very helpful. But here on this radiograph, you can see this almost complete bony ankylosis of that joint. On the right-hand panel, we see subchondral sclerosis. So increased bone mineral density at the cartilage bone interface. Here are along the portion of the scaphoid that's articulating with the trapezoid and trapezium bones here in this patient. And this is characteristic of osteoarthritis, subchondral bony sclerosis. So osteophytes can be seen in many, many different kinds of arthritis. This is a patient with osteoarthritis that has osteophytes here at this DIP. Here you see an osteophyte in the setting actually of a central erosion. So this is osteoarthritis, but erosive or inflammatory osteoarthritis, which gives you this. This is a patient who has a hook-like osteophyte. This is typically seen at the second and third MCP joint, and when you see that, you should be thinking about metabolic bone disease, such as hemochromatosis or CPPD arthropathy, and so you want to be thinking about that. Patients with hemochromatosis will often present with an arthritis that can look like rheumatoid, with lots of inflammatory disease of the second and third MCPs, but then you see these hook-like osteophytes, which are generally not seen in rheumatoid disease, but are seen more likely in hemochromatosis, so that should clue you in to be looking for that. So evaluation of the sacroiliac joints is a whole hour or two or 20 in and of itself, but I just want to point out this. This is a patient with active sacroiliitis, and you can see that the iliac portion of this joint has got a lot of sclerosis, and there's erosion across that side, and probably some widening of the joint in this setting of active sacroiliitis. And here on the upper right-hand panel, you see fusion of the sacroiliac joint. So with time in patients with radiographic axial spondyloarthritis, again, you'll learn about that further on in the VIP, you may have complete fusion of the SI joints and you don't even see them, they're gone. And so again, that can be very helpful when you're evaluating patients who are later in the course of the disease. Of course, this happens years down the road. So this is not going to be seen in your young patients who are presenting with inflammatory symptoms, but you may see it in an older patient, and we often will see that. So I also want to just point out that there are mimics of sacroiliitis, and this is one I want you to be aware of. This is called osteitis condensans ilii, and you get the sensation that this is this sort of triangular shaped increased bone mineral density on the iliac side, on the inferior portion of the sacroiliac joint. And we see this not uncommonly in women who are multiparous, so women who've had multiple children, because remember that your sacroiliac joints have to really open so that the baby moves through the birth canal. And so this is a response to that. It's not pathologic, it should not cause pain, and it should not be confused with sacroiliitis. So, you know, if you see this, you may want to ask the question, how many babies have you had? So lots of rheumatology is pattern recognition, and this is one of those areas. So the joint distribution, which joints are affected, not just an individual joint, where are the erosions, where's the swelling, but which joints are involved. So if you see a patient who has DIP and PIP joint involvement in the hand, you're going to be thinking about osteoarthritis primarily, either garden variety osteoarthritis or erosive osteoarthritis, which is going to have erosions, obviously. Psoriatic arthritis can look like this. When that happens, it's often DIP joint, inflammatory disease of the DIP joints can give you erosive disease with psoriatic arthritis. If you see new bone formation, helpful. MCP and PIP joint involvement is very characteristic of rheumatoid arthritis, usually with wrist disease, or not always, but generally rheumatoid arthritis is going to spare the DIP joints. So in early disease, that can be helpful. I think I have one patient with rheumatoid arthritis who has DIP disease, and I see a lot of RA, and I've been in this business a long time. So inflammatory disease of the DIPs should sort of move you away from rheumatoid arthritis. Psoriatic arthritis, reactive arthritis, ankylosing spondylitis, or the other axial spondyloarthropathies can give you erosion and new bone formation and can involve the DIP joints. MCP involvement alone, again, inflammatory arthropathies generally do this. We mentioned rheumatoid arthritis, hemochromatosis, CPPD arthropathy, and if you see osteophytes, you should be thinking CPPD, which often can coexist with osteoarthritis. And gout can basically do anything it wants to do. It goes anywhere. It can be monoarticular, oligoarticular, polyarticular, but it has a very characteristic radiographic appearance when there's damage. So again, just showing you the pattern of these joint involvement, PIP, primary OA, wrists, MCP, PIP with rheumatoid arthritis. Psoriatic arthritis can look almost any way it wants to also. It can be polyarticular like rheumatoid. It can have this ray distribution like I showed you here, just like every joint in a single ray. You can get inflammatory DIP joint disease. It can do a lot of things. CPPD arthropathy, I mentioned frequently the second and third MCPs, and often the radial side or even the ulnar side of the wrist. And then gout, as I mentioned, can really do anything it wants to do. And in the feet, similarly, gout, rheumatoid arthritis, really forefoot predominantly, but midfoot also. Psoriatic arthritis can do a lot of different things, reactive arthritis. I don't have osteoarthritis in this picture, but osteoarthritis is very characteristic in the first MTP. And sometimes it can be confused with gout. And I can't tell you how many patients have come to me with osteoarthritis, the first MTP, who've been diagnosed with gout without crystal, and the radiographs can help you sort that out. I also just want to mention diabetic neuroarthropathy or Charcot joint, which can give you a very erosive looking or cartilage eating arthritis, which is confined to the midfoot. So if you see that, you may want to be thinking about diabetic neuroarthropathy or a Charcot joint. I have just a couple of slides on radiographic measures. As you become rheumatologist, you'll be reading a lot of literature on inflammatory arthritis, and one of the outcome measures that are very important in clinical trials is radiographic damage. There are several different methods out there. The one I think that's most highly accepted, and now most studies that are looked at the FDA, is the Van der Heide modification of the Sharp score, and that's what I'm going to show you here in a minute. I don't generally use this in clinical practice. It's helpful to know the scoring because as you read the literature, it'll help you to understand what they're talking about. But knowing what it is can help you understand a little bit more predominantly about rheumatoid arthritis. So these are the joints that are measured for erosion here on the left, and you're looking at the hands and the feet, and then the joint measured for joint space narrowing. And each joint is measured separately. Bless the people who sit in dark boxes and read these things all day long. We owe them a debt of gratitude because this is hard work and it's very difficult to do. They look at each joint, and each joint is measured for joint space narrowing on a 4-point scale and erosion scoring on a 5-point scale. And you add together joint space narrowing and erosion, and you get your Sharp Van der Heide scoring for RA with a range of 0 to 448. So that's helpful to know as you're reading clinical trials. So in our last couple of minutes, we're going to do some practice cases. And I think Janet has some polling she's going to help us with. So here's our first case. I want you to take a minute and look at the film and tell me, what is your diagnosis? Is it rheumatoid arthritis? Is it psoriatic arthritis? Is it osteoarthritis? Is it gout? Or is it CPPD arthropathy? So take a minute and submit your choice here. Can I see the polling? Let's see. Here we go. All right. So very good. 89% of you got osteoarthritis, which is exactly correct. I will say that osteoarthritis can sometimes be confused with psoriatic arthritis, but in this case, I think we've got a central erosion here. We've got the gull wing deformity. We've got DIP and PIP involvement. We've got really sparing of the MCP. There's probably some osteoarthritis here at the scaphoid trapezoid triquetrum articulation. So this is osteoarthritis. Great work, guys. Okay. Now, how do I go to my next slide? Here we go. Question number 2. Take a look at this film and tell me, is this rheumatoid arthritis? Is this psoriatic arthritis? Is it osteoarthritis? Is it gout? Or is it CPPD arthropathy? So you're going to look at soft tissue swelling. You're going to look at subluxation. You're going to look at the joint with itself. You're going to look for erosion. Great work. So 97% of you got it right. This is rheumatoid arthritis. We've got involvement of the MCP joint. We've got joint space narrowing. That's uniform. We've got an erosion here. We've got ulnar deviation. Strong work. Okay. Next picture, does this patient have rheumatoid arthritis, psoriatic arthritis, chronic gout, or erosive osteoarthritis? Again, you're going to go through this film in a very systematic way. You don't want to miss soft tissues, calcification, alignment, joint space narrowing, erosive disease. All right, so this is great. I'm glad this is exactly the way this came out. So this patient actually has erosive OA. 42% of you got this right. But I'm going to also tell you that this is often confused and can be confused and hard to differentiate from psoriatic disease. So, you know, I think this patient probably has OA, but you know, if this patient had a lot of psoriasis on their body, you might call this psoriatic disease. And in my clinic, I have a group of patients that I think are very hard to distinguish based on their radiographic features, but this patient does have osteoarthritis. Okay. So the patient in this film is scheduled for a left total knee arthroplasty. We can't do much with our medicines anymore. And so she is going to surgery. Which form of arthritis is the most likely cause of this patient's end-stage disease? Is it osteoarthritis or rheumatoid arthritis? So again, here you're going to want to look at joint space narrowing, presence of osteophytes to help you make this diagnosis. All right, so pretty evenly split. So the correct answer here is rheumatoid arthritis, and let me explain why. So this left knee is essentially bone on bone in both the medial and lateral compartments. So uniform joint space narrowing. Now, I will tell you that you will get this x-ray back from your radiologist, and the radiologist will say that the patient has osteoarthritis. But you know this patient has rheumatoid arthritis because both medial and lateral joint widths are compressed equally. There's osteophytes, but really considering the degree of joint space narrowing, really very little in the way of osteophyte. And even on the right knee, which is less affected, there's pretty uniform joint space narrowing and a paucity of osteophyte. So this is rheumatoid arthritis. And again, you know, we're just getting started here. I want you to look at a lot of films and you want to be able to tell this. Okay. So what is your diagnosis here? You have a left hand. Is this rheumatoid arthritis? Is this psoriatic arthritis? Is this osteoarthritis? Is this gout, or is this CPPD arthropathy?
Just want to remind you, Dr. Jonas, that we have 3 minutes.
Oh, okay. I have one. Gout. Yes, strong work, everybody. We're going to go on to the last question. This is the brain teaser. We didn't discuss this. This is a 45-year-old woman who's had a CVA, completely unrelated to this process, with chronic sinus disease related to this process. And she presents with hand pain. What is your diagnosis? I'm going to give you just a few seconds for this one. This is the brain teaser. All right, a lot of you got this. So chronic sinus disease was the clue here, but radiographically, I want to just show you this sort of lacy pattern of the bones here, loss of cortex, and this is a patient with osseous sarcoidosis. I didn't expect you all to get this, but this is how much fun reading x-rays can be, that you can make a diagnosis of sarcoidosis on a hand film. So I am going to stop there and just make this one reference. Arthritis in Black and White is a really nice resource. It's a very short book and gives you a lot of the material I presented with you this morning. So it's a really nice book to have, and it's available on most of the library websites at major institutions. So I'm going to stop sharing, and I'm going to let the crew ask me a few questions.
Well, thank you very much. It was very informative. I really, I learned myself from it. So thank you very much. And yeah, I agree with your comment that it's like lifelong process. So they need to learn so much in their fellowship, but then they keep learning as time passes. So a couple of questions. Let me ask the first question. So the first question is asking about if the patient is looking good, no clinical signs of progression of disease activity, how often you repeat the x-rays to assess disease?
Yeah, that's a really good question, and there's no right or wrong answer, and I'm going to just tell you how I do it. the reason to get the x-ray is to make sure that the therapy that you've chosen is really working. The vast majority of the time, you're going to be able to do that assessment based on your clinical evaluation, your history, and your physical examination. Occasionally, though, there are a subset of patients who have radiographic progression, and I'm talking primarily about rheumatoid arthritis now when I'm making this recommendation, that will have radiographic progression that's sort of uncoupled from their disease activity scoring that you're going to do in the clinic. And so in those patients, usually maybe every 2 or 3 years in patients who are well controlled, I will try to get radiographs. Occasionally I'll see someone back and I'm like, sheesh, I haven't gotten x-rays in 5 to 7 years. Most of those times it's because the patient's been so, quiescent and I don't do it. If you have a patient that's very active and you're having trouble controlling the disease and you're clicking through a lot of medicines, a couple of things I like to get x-rays more frequently. I would never x-ray more frequently than once a year because the change is, the x-ray is not that sensitive to change. But if you have someone who you have difficulty controlling, every 1 to 2 years, I think is very reasonable. Sometimes I will also do it, like if I have the sensation that things are smoldering and progressing and the patient is resistant to change, so I think they need a new biologic or intensification, and I can't get them to get on board with me, I will sometimes get radiographs and show them, this is what's happening. And between, this has happened in a year or 2 years, think about 30 years down the line, what is things going to look like? Because we know erosive disease really is coupled with function and damage over time. So there's no right or wrong answer. You're going to use your clinical judgment, never more frequently than once a year, and sometimes longer if everything is going really well.
Okay, I'll let Dr. Dia Obeidat, our fellow, to ask you the second question, but then after that, feel free to take over because you're going to be moderator for the next session. So answer the second question and then take over.
Okay.
Great speech, Dr. Jonas, by the way. So the second question is coming from an anonymous attendee. They're asking if the joint space narrowing is only localized for the second and the third MCP. Would that be more consistent with OA rather than rheumatoid arthritis?
No. So yeah, I guess there's no yes or no to this answer. And again, you're going to make your diagnosis on completely clinical grounds. The chance of having isolated MCP joint space narrowing without anything else is very uncommon in OA and much more common in RA. So if you've got DIP joint disease and MCP joint disease, then that's going to move me more toward OA. If you have PIP and MCP, that often leads me more to RA. The teaching used to be that you could not have MCP joint disease in OA, and that we know, actually based on data here from North Carolina from the Johnston County Osteoarthritis Project, that that's completely untrue. But if you have second and third MCP joint disease, I might be thinking more RA, but you want to remember about hemochromatosis, CPPD arthropathy, and I think OA would be a little bit further down my list.
Okay, thank you, Dr. Jonas. And I think this is pretty much the same question that we had previously answered. How often do you repeat x-rays and follow up for RA patient, which I think you covered that topic. Okay, so if this is all the questions that we have, it was a great pleasure, Dr. Jonas. Thank you so much for a great presentation. And we will let you take it from here for the next presentation.
Excellent. Thank you so much for being here and for moderating this session with me. And we're going to move on. Actually, I'm going to take a 30-second break, and I want you all to also, I'm not going to stand up, but everyone at home or in your clinic or wherever you are, stand up and stretch, because movement is medicine, and we should not sit too long. Sitting, it's the new smoking. So wait, maybe I will stand up. So I'm going to practice what I preach. I'm going to stand up, I'm going to move away, everyone should wiggle their legs and move. Okay, we're back. So I'm very pleased to be here, and I'm going to go through this sort of housekeeping slide again, although probably you've all heard this a million times, but if you want to make a general comment or having some technical difficulties, you can use the chat. If you raise your hand, the host will help you out if you're having any trouble. And the Q&A for this session, like the previous session, will go in the Q&A box. And so please put your questions in the question box. I am pleased to actually introduce my co-moderator, Dr. Dalal Mohammed, who will be joining me here to moderate questions and answers as we go along. So I'm going to actually stop sharing my slides here. Hang on. Oh, no, I am stopped sharing my slide. Lisa, these are yours. Excellent. Perfect. So I am really pleased to introduce Dr. Lisa Zickuhr, who is our next speaker who's going to talk about laboratory testing. So lots of stuff about ordering today. Dr. Zickuhr is Assistant Professor of Medicine in the Divisions of Rheumatology and General Medicine at the Washington University School of Medicine in St. Louis, where she serves as Associate Director of the Rheumatology Fellowship Training Program, Associate Director of the Medicine Clerkship, and Director of Rheumatology Curricula. So she wears a lot of rheumatology hats. Clinically, she's interested in caring for patients with autoimmune and connective tissue disorders, and she treats patients at the WashU School of Medicine Lupus Clinic. Academically, she investigates underrepresentation of patients with lupus and skin of color in educational resources, as well as the efficacy of acting learning methods in educational practice. She is a current recipient of a Clinician Scholar Educator Award from the Rheumatology Research Foundation, where she's studying best practices for shared decision-making during virtual care, something we've all gotten very familiar with in the last year, and to evaluate methods of teaching trainees virtual care. So Dr. Zickuhr, it's a pleasure to have you with us this morning.
Thanks, everybody. Thanks for that great introduction. I am excited to talk with you today about some of the real workhorses of evaluating patients with musculoskeletal and autoimmune complaints, the basic labs that we always check to order. As Dr. Jonas said, I am talking at you from St. Louis in clinic. You get to see a rheumatologist in her natural habitat here. But St. Louis, if you haven't been, it's the land of the Mississippi River, the St. Louis Arch, toasted ravioli, and Budweiser beer. So come make a trip anytime. All right, so I have no financial disclosures. My objectives and my goals for you by the end of this talk is that I'm hoping you're able to describe how these labs are performed in the actual lab, and to be able to make associations between lab findings with the prototypical autoimmune diagnosis, as well as being aware of how different patient conditions and comorbidities may influence how you interpret these results and what they mean in the setting of individual patients. So how we're going to accomplish this is I have a true story that I'm going to share with you throughout the course of this talk. And posted to the website were a series of case questions that were available to you to look at beforehand. If you didn't have an opportunity, it's okay. You can log in now and download them, but we'll also look at them through the PowerPoint slides. So these case questions will kind of frame the discussion as we move through a conversation about ESR and CRP, followed by rheumatoid factor and anti-CCP, and concluding with ANA and ENA. And as we cover each of these pairs, we'll talk about what the test is, how it's performed, the prototypical disease, and then caveats, influencing factors, and any surprises that you might need to be aware of in terms of interpretation. And then lastly, after the conclusion of this talk, there will be a list of, I think it's 6 or 7 more questions that I wrote. These are knowledge transfer questions that will highlight other topics that are covered in the talk, but in a different way. So to help cement in some of these concepts, you can look at those on your own if you're so inclined afterwards. All right, well, let's start with the true story. So in my clinic, a couple years ago, I saw a 56-year-old woman for a headache and hand pain, and she had a history of anxiety, fibromyalgia, metabolic syndrome characterized by hypertension, hyperlipidemia, obesity, and diabetes type 2, as well as common variable immune deficiency requiring monthly IVIG infusions. And so a month prior to seeing me, she had introduced herself to a new primary care physician where, while she had this chronic history of migraines, the PCP was concerned because it sounded like her headaches had evolved to being this constant pain over the temples associated with all over body pain and stiffness. She took some pictures of her hands. You didn't think that there was any swelling there, but she did. So this leads into the first part of our talk. I have inflammation in my body, or the tale of ESR and CRP. So because of all these symptoms, the PCP ordered an ESR and CRP. Her ESR was elevated to 62 and her CRP was also elevated to 12.6. I'm going to give you a little tidbit. The CRP units, they vary based on what the lab uses. So sometimes the reference range is less than 1, and in other times it's less than 10. So you just have to be cautious of what the reference range units are when you're interpreting a CRP. So my question to you is, what is the most likely cause of the patient's elevated inflammatory markers? Is it autoimmune disease, infection, malignancy, or none of the above? And I believe we have a poll. Here we go. I actually don't see the poll. Oh, here we go. All right, excellent. So we have mostly people are saying none of the above and a couple smatterings of autoimmune disease and maybe infection or malignancy. I agree, none of the above is the correct answer, largely because I wrote the question. But anyway, so let's get into the reason why it's none of the above and maybe explore why this patient's ESR and CRP remain elevated nonetheless. So what is an erythrocyte sedimentation rate? I'm going to call that ESR moving forward. Too much of a tongue twister otherwise. Well, it's literally a velocity. It's just like what it sounds, it's a rate. And so what they do in the lab is they take patients' blood and they put it into these little vials, and then they let it just sit on the table for an hour. And over the course of an hour, they measure the distance in which all of the proteins and the cells sediment out, and how much all of those cells travel over the course of an hour. So the farther that things travel, the farther the distance, and therefore the greater the sedimentation rate. Well, why does this happen? Why does blood sediment faster if there's inflammation? ESR truly is a marker of inflammation, and this is the reason why. When there's inflammation happening systemically, your body releases these pro-inflammatory cytokines like IL-1, IL-6, TNF-alpha, the oldies and the goodies in rheumatology. And you'll learn more about these throughout the course of the VIP practicum. And these cytokines go to the liver and they tell the liver there's inflammation and please make all these pro-inflammatory proteins like fibrinogen, C-reactive protein, haptoglobin. Furthermore, this mechanism of inflammation works on the adaptive immune system and antibodies are produced. And so when all of these proteins and antibodies are produced, they actually block the repellent forces that naturally occur between individual red blood cells. And the result is rouleau formation. So you get chains of red cells stuck together and conglomerated together. And you can imagine how a chain of red blood cells is much heavier than a single isolated red blood cell. And so that chain will fall faster and sediment out more quickly, thereby raising the ESR. So what are the prototypical disease associations associated with this? Well, if you haven't done an inpatient consult month yet, this will be your differential for almost all medical mysteries. And is it infection? Is it malignancy? Or is it an autoimmune rheum disease? And when we get a little bit more into the nitty gritty, it really becomes with elevated ESR, bacterial infections, malignant heme type of conditions. And then in rheumatology, the most prototypical diseases associated with elevated ESR are polymyalgia rheumatica and the continuum with giant cell arteritis, lupus, and vasculitis. Well, you may ask, well, what happens when the ESR is really, really, really high, like above 100? And this has a little bit of a different differential. So about a third of cases are bacterial infection. A quarter are rheumatologic manifestations like GCA and PMR. A quarter are miscellaneous. And then 15% are malignancy. So if you had to bet, you could bet on us, the autoimmune diseases, and on bacterial infections when you see an ESR raised this high. Now, there are influencing factors that can affect the sedimentation rate when it's measured in individual patients. The first is age. So I'll get into this a little bit later. I don't want to talk too much about it right now, but there's this concept of immunosenescence, where as we age, basal levels of inflammation in terms of ESR and CRP naturally rise. The other factors work directly on the liver. So female sex and obesity, it's thought that female sex has, compared to men, females have more adipose tissue. And as we know, adipose tissue can be pro-inflammatory. And so when there's more of it, because you're either a female or because you are obese, that is a pro-inflammatory state that works on the liver to increase the production of these pro-inflammatory proteins. Pregnancy is also associated, and this can be through a mechanism that it's thought that the placenta directly makes CRP and some other pro-inflammatory acute phase reactants. But the other thought is that anemia also contributes because you increase your serum levels when you're pregnant, and anemia, anemia itself can also increase the ESR. So how does anemia affect the ESR? Well, when the blood is in a column, the red cells actually create some buoyancy for the other red cells above or higher up in the column. And so without that mass there to create buoyancy, the few red cells that remain sediment much quicker. And then lastly, IVIG is exogenous antibodies. And so by adding antibodies, you are increasing rouleau formation and increasing the sedimentation rate. So in our patient, she had several risk factors that will increase her ESR without having a concomitant infection, malignancy, or autoimmune condition. Namely, she was over the age of 50, she was female, obese, and was receiving IVIG. And so for these reasons, it was thought that none of the above was probably the best answer. All right, so let's switch gears and talk about CRP. What is it? Well, it's an acute phase reactant, the C-reactive protein made by the liver in the setting of these pro-inflammatory cytokines. And its purpose actually is to help opsonize foreign bodies and enhance their clearance. It too is a genuine marker of inflammation. But what's really interesting about CRP is that it's much more sensitive and it gives you much more timely information than the ESR. So what do I mean by that? Well, in this chart, we have on the x-axis time after inflammatory stimulus in days. And on the y-axis, we have the change in plasma concentration as a percentage of these various inflammatory acute phase reactants. And you can see haptoglobin, fibrinogen, complement 3, transferrin, they all kind of, they kind of drag a bit. It may take them 7-14 days before their peak after an inflammatory stimulus before they then return to normal. And their levels don't change that much. But if you look at CRP, which is the dotted line alongside serum amyloid A, it rises very quickly and to a really high peak. And then it falls relatively quickly too. So if you're ever wondering, is someone's inflammatory status or condition getting better, worse, staying the same, checking a CRP is probably more sensitive than following the ESR, at least in the short term. So how is CRP measured? Well, it's a form of solid phase assay called nephelometry. Let's try saying that 10 times fast. And so this is kind of similar to an ELISA, if you remember that from college biology days. And what happens is that there's this tube in the lab and it contains all these beads. And the beads have antibodies that bind CRP. And so you add patient serum and any CRP that is present will bind to these beads. And when that happens, it causes the beads to agglutinate. And then they shine a light through the tube. And based on how the light scatters, there's a math and a computer program and things that I don't know, and I don't know if I want to know, but based on how the light scatters, they're able to determine what the concentration of CRP is within the patient's sample. So nephelometry. What are the prototypical disease associations with elevated CRP? The same as ESR. Infections like bacterial, malignancy, and rheum, and really, really high CRP levels. This is a little different than super elevated ESR in terms that cancer is mostly widely metastatic disease, not necessarily always malignant heme. And then in terms of rheumatology and autoimmune conditions, we think of polyarticular crystalline arthropathy like gout or CPPD, as well as vasculitis. So what factors influence the interpretation of CRP? Well, some of them are very similar to ESR. Age, immunosenescence, and I'm going to go into that more deeply on the next slide. Female sex and obesity because of the thought of increased fat adiposity. Pregnancy because it's thought that the placenta actually creates C-reactive protein. And what you'll notice here is that our patient was female, obese, and had advanced age. All of these things could contribute to her elevated CRP level. Now, one clinical pearl is that, if you recall, antibodies and anemia could affect ESR. So if a patient has anemia or is getting IVIG, CRP is not affected by these things. And it could be a potential, a better, more reliable marker of inflammation than ESR. All right, well, let's finally talk about age and how that affects ESR and CRP. So this is the concept of immunosenescence, which basically says that as we age, starting usually around age 50 and older, the innate immune system isn't as facile as it used to be. And so to compensate, the body actually increases, the adaptive immune system isn't as facile as it used to be. And so to compensate, the body actually augments its innate immune system and raises basal levels of inflammation in the form of ESR and CRP. And so you can see this is more pronounced in ESR. So in this bar chart, we have age on the x-axis and ESR level on the y. Here's CRP on the y-axis and age grouping on the x. And you can see that with time, there is a rise in ESR, and then you can kind of imagine this itty bit rise in CRP as patients age. And this has been shown in several different studies and is widely accepted to the point where, in fact, there are corrective formula so that you can adjust your ESR and CRP levels by both sex as well as age. And I list those there for you. I really don't usually adjust CRP clinically, but I'm always adjusting ESR, especially for those consults where the ESR level may be elevated just because a patient is a little bit older rather than reflecting an underlying infection, malignancy, or autoimmune condition. All right, so to prove that these stories that I'm telling you are true, this is a sample of this patient's ESR and CRP. So you can see she always had elevated inflammatory markers, and it was around this time where she started getting IVIG, so her inflammatory markers really skyrocketed. Her PCP checked them back in March of 2020, saw that things were really high, freaked out, put her on prednisone, said, you have PMR, go see your rheumatologist. And I thought things were largely from fibromyalgia and all of these other comorbidities. So I tapered her prednisone over time, and you can see how even with on the steroids, things never really normalized, and got her off the steroids. Her labs stayed the same, and her symptoms stayed the same as well. So this is why I actually really like thinking about ESR and CRP, because it's a great exercise in remembering how physiology and physics can influence your labs and thinking about that in the clinical context. All right, let's move on to there's rheumatoid in my blood, the story of RF and CCP. So our true story continues. You ask her some more questions about her hand pain, and she says that my hands are inflamed, all of my joints are swollen, I'm stiff all day. When I have to do things, my joints hurt even more. And so her PCP had so kindly ordered an RF and a CCP for you, both of which were very barely elevated at 16 and 24 respectively. So what is the best explanation for the patient's positive RF and anti-CCP? Is it infection, medication effect, metabolic syndrome, or rheumatoid arthritis? And I think we have a poll. All right, so kind of a mix between B and C, medication effect and metabolic syndrome. So the correct answer here is actually medication effect. So the IVIG has gotten us again, and anytime that you have a patient who is getting exogenous antibodies, these are IVIG are basically antibodies donated from a bunch of different people, pooled together and then given to patients. You always have to be really leery about how you interpret serologic studies, especially when they're just barely positive. So serologies are always difficult to interpret in the context of patients who are getting IVIG. We'll go through this a little bit more in the coming slides. So what is rheumatoid factor? Well, rheumatoid factor is any antibody that binds to the FC portion of an IgG. And historically or evolutionarily, it was developed because these antibodies helped clear immune complexes. The most common form of rheumatoid factor is actually an IgM, and this classically exists in a pentameter, which is what the figure here is displaying. So what's black or gray and white is the rheumatoid factor pentameter, and then it's binding to the green FC portion of a random IgG. And this is all rheumatoid factor is. So prototypically, how is it measured? Well, back in the day, they used to use latex agglutination. So they would have these latex particles that were studded with gamma globulin, and then they would add patient serum. And if there was a rheumatoid factor present, it would create these things to cause the latex particles to agglutinate. We don't use that so much anymore. I think I've seen it like once in the last 3 or 4 years. Instead, we use more solid phase assays like ELISAs and nephelometry. Those are the more common ways that rheumatoid factors are measured currently. What is it most commonly associated? Well, it's in the name. Rheumatoid arthritis is the prototypical disease association, but I offer you a word of caution because rheumatoid factor is not at all specific. Remember, it's just an antibody that binds to another antibody. And so there's lots of things that can cause that. In fact, there's a whole list here for you that describes all the things that can cause excess antibodies that bind to other antibodies. Things like Sjogren disorder, lupus, they develop antibodies to everything. Chronic infections like hepatitis C is probably the most common. Vasculitis, cryoglobulinemia. Oftentimes the actual cryoglobulin is a rheumatoid factor. You can also see elevated rheumatoid factors in patients with ANCA-associated vasculitis. So the list is long. And in Rheumatology Secrets, I love Rheum Secrets. I still read that book all the time. I read it cover to cover when I started as a fellow. If they don't pay me, but if you need a good resource, that's the one I recommend because it's so short to the point and so informative. But they have a great mnemonic, chronic, that will help you remember all of the conditions that can cause an elevated rheumatoid factor. Chronic diseases, rheumatoid arthritis, other rheumatic diseases, neoplasm infections, and cryoglobulinemia. So don't always think rheumatoid factor equals big arrow rheumatoid arthritis because that association does not always hold. However, CCP is a little bit different. So what is anti-cyclic citrullinated peptide antibodies? Well, it's an antibody that binds to cyclic citrullinated peptides. And what happens is that in proteins that have an arginine attached to them, sometimes they can undergo a conversion from arginine to citrulline, which changes the charge of the antibody of this part of the protein from a positive to a neutral. And when that happens, it changes how protein folds, and it can expose parts of a protein that previously weren't exposed before. And these anti-CCP antibodies bind to the citrullinated portion of these proteins. There are different environmental triggers that can enhance the antibody production process to this, namely smoking, mucositis, and I can think of some other things like microbiota, flora kind of issues, gingivitis. You'll learn more about that when you learn about rheumatoid arthritis and the environmental triggers that can influence the development of it. But these things are directly related to the production of anti-CCP. So how is it measured? It's measured with an ELISA, and that's how we get our results. And its prototypical disease association is rheumatoid arthritis. And it, unlike rheumatoid factor, is not associated as influenced by all of those other conditions. And so if you're looking for rheumatoid and you have someone with a really high titer CCP, CCP is much more specific than rheumatoid factor is for rheumatoid arthritis and the diagnosis of that patient. All right. So let's move on to my lupus test is positive, the woes of ANA and ENA. So on review systems, our patient is pan positive. I'm not going to go through her review systems. It's right there for you. It covers 3 lines. She has labs, namely a complete blood count, a CMP, and a UA. And her PCP is worried that she still has an autoimmune condition, so she orders an ANA. Well, what is an ANA? It too is an antibody. It's an anti-nuclear antibody. And these antibodies are anything that bind to RNA, DNA, protein plus nucleic acid complexes, things that typically live in the nucleus, as the name suggests. And these are naturally occurring antibodies. So if you think about it, over time, we always have cells growing, dying, undergoing apoptosis, and essentially extruding internal contents to the outside world. And so these antibodies have been developed to help clear that rubble and clear the cellular debris. And they aren't a problem. They can be there and they don't cause any harm unless a patient has a break in self-tolerance. And then at that point, these anti-nuclear antibodies will then turn inward and cause damage rather than just focusing on helping to clear cellular debris. So there are 2 ways to measure ANA. The first is an ELISA test. And this has a sensitivity and a specificity around 80%. The good thing is, I mean, that's pretty decent sensitivity and specificity around 80. That's not terrible. It's not perfect, but it's not bad. It's very easy to do this because it's all automated through a machine. It's reproducible because it's all automated through a machine, and it's cheap because it can just be prepackaged in little kits. However, it's not considered the gold standard. Instead, indirect immunofluorescence is the gold standard. So what do we do in this case? Well, there's this glass slide, and on the glass slide, these HEP2 cells are adhered to the glass slide. And the HEP2 cell is chosen because it has a large nucleus with a lot of those nuclear protein type of antigens on them. And then the lab technician will take the patient's serum and squirt it on top of the HEP2 cell. And then on top of that, they'll squirt a detection antibody that has a fluorescent tag. And this then will give us an idea based on if we can see fluorescence under the microscope to see if an ANA is present. But not only does that fluorescence tell us if an ANA is present, it also can give us a staining pattern that might help us get an idea of what type of autoimmune connective tissue disease a patient may have. And with all of this extra rigmarole, our sensitivity increases to 93%. However, this happens at a cost. Happens at a cost for specificity, which falls to 57%. And I am including here the ELISA sensitivities and specificities for a comparison. It also comes at a cost of financial cost. This whole process takes a lot more time and money than a simple ELISA. It comes at a cost of reproducibility because it is dependent upon the ability of the lab technician to do this and interpret the test well. And then it requires a lot of training. Lab technicians have to be trained to perform this procedure as well as actually look through the microscope and identify the presence or absence of a positive ANA. And so with all of this, if you don't remember anything from this talk, just remember this. ANA is sensitive, but not specific, which means that if it's there, okay, maybe that helps you, maybe it doesn't. But if it's not present, that does help you exclude or rule out a good number of diseases. I'd like to talk a little bit about the staining patterns that you can see using indirect immunofluorescence. So these staining patterns historically, before we had the ENAs, would help practitioners be able to subtype the type of disease. In the more recent literature, this is a little bit more controversial, and it's actually thought that the pattern may not be that useful, except for one, maybe two exceptions, and that is the centromere staining pattern and maybe the nucleolar. So centromere is very specific for having the presence of an anti-centromere antibody, which is seen in limited scleroderma and crest syndrome. And nucleolar staining patterns often correspond with other scleroderma type of ENAs, like anti-SCL70 or THTO, that kind of thing. So I personally don't really look at the staining pattern anymore, and I really don't pay attention to it unless it shows me a centromere pattern, and maybe if it shows me a nucleolar pattern, will it catch my attention. So what is the prototypical disease associated with ANA? Well, it's lupus, isn't it? Actually, not quite. This is what a lot of the primary care physicians will say. And so the patient's going to come to you and be like, my lupus test is positive. I have a positive ANA. And I can't tell you how many times I wish that I had this meme to just put into my note in my assessment and plan. And instead, whenever you see an ANA, I hope that you come from a place of no rather than a place of yes, because like house, most of the time it's not lupus. And so what do I mean by that? Well, ANAs are associated with a lot of different diseases. I love this table. This is, if you go to UpToDate and you type in anti-nuclear antibody and go to table 1, this is the table that will come up. I pull up this table at least once or twice a week when I'm teaching in clinic, because it shows you so well how there is a long list of conditions that are associated with the ANA, and they're not all lupus. So yes, lupus always has an ANA, at least that's the rule of thumb. But if you look at some of these other conditions, scleroderma, 95% of the patients have an ANA. Rheumatoid arthritis, half the patients have an ANA. The autoimmune thyroid diseases, half of them have a positive ANA, and this even extends to chronic infections and malignancies. And so whenever you evaluate a patient with an ANA, instead of thinking positive ANA equals lupus, I encourage you to consider positive ANA equals potential autoimmunity, because as you recall, these antibodies can also naturally exist in the body because they are involved in the removal of cellular debris. So positive ANA equals potential autoimmunity or healthy individual. So that brings us to our question, and you'll recall that this patient is PAN positive, has normal basic labs, had a positive ANA, and her PCP wants to order an ANA. So which statement best describes the best approach to ANA testing in this case? It's warranted to further evaluate the patient's symptoms and elevated inflammatory markers. It's warranted to further evaluate her symptoms and low titer rheumatoid factor. It's not indicated because an infection is the likely cause for all of her symptoms and elevated inflammatory markers, or it's not indicated because the patient's symptoms do not raise your suspicion of an autoimmune connective tissue disease at this time. So we will start the polling. All right, almost everybody said it's not indicated. I think that's totally reasonable. I'll also say that depending on your clinical gestalt, maybe even A is warranted. So this one didn't really quite have a right answer, but I am totally on board with D. And for those of you who also selected A, I don't think you're totally out of the range of possibilities or off base either. So why is that? Why am I saying that you could have possibly two different answers? Well, all of this really boils down to the sensitivity, the specificity, and the test characteristics of ANA testing. So if you're like me, I memorized the stuff in med school, didn't really understand it, and moved on. I'm not really mathematically oriented, but I had the opportunity to take a biostats course last semester, and I did, and part of it was on test characteristics. And I have to say, after all of my experience with ANAs, Oh my gosh, all of it made total sense. So if you don't understand what I'm about to say now, don't worry. In about a year after some experience working in the room environment, you will definitely come to learn all about this in a clinical manner. So let's talk about the influencing factors. The first is the reference range. So a random reference range of an ANA with a titer greater than or equal to 1 to 160 was set at the cutoff. And this was set because 5% of people that had a titer equal to or greater than 1 to 160 don't have disease. So, you know, that's pretty good bets. Like if someone has this titer, and if you had to bet on something, you know, that they had disease, you'd only be wrong 5% of the time. However, it's not perfect because, and then anything less than this was declared negative. This cutoff though isn't perfect because still 5% of the normal population will have a titer without having disease that's greater than or equal to 1 to 160. And there are various factors that influence this, like age. So as we age and get older, we've had longer time to accrue these anti-nuclear antibodies just on the purpose of them helping to clear cellular debris. Family history has an effect. Those family members with known autoimmune disease, in particular lupus, tend to have a positive ANA, but doesn't necessarily equate to an autoimmune condition. Medications can influence this, and the list goes on, but age and family history are the most prevalent. So the titer of greater than 1 to 160 was set because it's hedging your bets, but it's still not perfect. The other part that I'd like to highlight here is that the titer matters. So because of how, basically as your titer for ANA rises, the likelihood that you have an associated autoimmune disease also increases. So you can see here, this is from a cohort that was published in 2000. Lower titers, normal people with positive ANAs at like 1 to 40 or 1 to 80, you know, 10 to 30% of people can just have this and not have autoimmune disease. But as you go beyond the 1 to 160 titer and higher, that level becomes much smaller, going down to 3% for people without disease who have a titer of 1 to 320 or greater. And so the corollary of that is the inverse. So if only 3% of people with a positive ANA of 1 to 320 have no disease, and that means 97% of people with that titer do. And you know, you can go on to 1 to 640 and beyond that. And as the titer rises, the likelihood that a patient has an autoimmune connective tissue disease continues to increase. So why am I going through all of this? Well, we use all of this information when we're in the clinical setting to help us interpret these labs. So this is a Fagan nomogram. We never use that. I never use this clinically, but in reflection, you know, this is kind of like what our clinical reasoning is representing. So in the line that's on the far left, we have the pretest probability. And it ranges from very low pretest probability of having a certain disease at the top, all the way to the bottom, which is a higher pretest probability. And where do we get this? Well, we get this from our clinical gestalt, taking a history, doing the extensive room review systems, and completing a physical exam. And this gives you some sort of hunch of how likely a patient is to have X, Y, or Z different condition. In the middle is the likelihood ratio. And this is a test characteristic. So based on how the ANA, if it's positive or negative, and what the titer is, and using a specific patient population cohort, you could look this up and you could plot on this line what the resultant likelihood ratio is. This comes from literature. So basically what you would do is you put a mark on your pretest probability, and then you put a mark for your likelihood ratio, and then you draw a line connecting those two dots and intersecting the post-test probability, which would give you the likelihood that a patient had the disease in question, lupus, whatever. And so the reason why I set this out is because you can see, based on how these numbers are staggered and stacked, you know, your pretest probability really sets the stage for how useful the ANA is going to be for you. Because if you have a really low pretest probability of 0.2% all the way up here at the top, and then, you know, the ANA titers maybe 1 to 80, and that gives you, I'm just pulling this out of thin air, that gives you a likelihood ratio maybe 0.05, and you connect those two, your post-test probability is all the way down here at the very bottom. And so for a test that is so fraught with variation, because normal people can have a positive ANA and meds can change it and your family history can change it, it's really important that we really root our ANA testing in a good history and a solid physical exam and clinical gestalt, so that we can then appropriately interpret these results in the clinical setting. So it's a complicated lab, and it's a fun lab once you kind of get the hang of this, and it's also what makes rheumatology so exciting, because it all goes back to the clinical diagnosis of treating the patient and not the lab result. But you just have to proceed with an air of caution when you're looking at ANA tests. So our patient, her ANA is 1 to 80 homogeneous. She comes to you for further evaluation. You just hold her IVIG so that it's no longer interfering with any of the tests, and you check an ENA. All right, so what is an ENA? Well, it's an extractable nuclear antigen, and I have them all listed for you in the table on the right. These antigens are essentially a subset of anti-nuclear antibodies. So once you have a positive anti-nuclear antibody, you know it's binding this RNA, DNA, combination of those things with protein. Then you want to know what's the specific name of what's that specific antibody that you're detecting with the ANA. That's what the ENA is. And so it's often recommended to screen with an ANA, and if that's negative, then you're done. But if you have a positive ANA, then to move forward with an ENA and further elucidate what exactly is going on beneath the surface. And why, clinically, why does this matter? Because these different extractable nuclear antigens are associated with different diseases. And I'll go back to how it's measured in a second. So we learned all about this in med school, but like SSA and SSB are classic Sjogren syndrome antibodies. Double-stranded DNA is the classic lupus, along with Smith, et cetera, et cetera. And what's fun about these antibodies is that they can give you an idea of how a patient's disease will progress over time. Or in other words, they can help you phenotype the disease. So for instance, double-stranded DNA is closely correlated with lupus nephritis, while an anti-RNP in the setting of lupus can be associated with pulmonary arterial hypertension. And so for these reasons, I actually find the ENA much more helpful than an ANA, which I think probably all rheumatologists do, because it can give you clues and insights into what a patient might be experiencing now or possibly down the line. So how is the ENA measured? Well, it's solid phase assay with nephelometry. And this is important because the ENA comes pre-packaged from the lab manufacturing company. It comes in this tube with all the beads and all the things, and it's all run the same way, regardless of what lab is doing it. But here's the kicker. The lab company or insurance, I don't know who does this, but the patient is only billed for the results that are reported out from this tube. So I know, for instance, at Cleveland Clinic, they report all of the ENA, all of those antibodies listed in the ENA panel. At WashU, only Smith, SSA, SSB, JO1, and SCL70 are reported out. And so wherever you are, just be aware of what's actually being reported. And you may need to consider what isn't being reported in your ENA results if you're still thinking that a patient may have an underlying autoimmune connective tissue disease, and you may have to add those on specifically because all of those things are decided by the individual lab setting. And then before I end, I'd like to leave you with one clinical pearl, and that is be weary of an isolated low titer RNP. So this is a table that was published in an abstract at ACR in 2017, and it compared low titer RNP results just by itself, to high titer RNP results, to RNP results that were associated with additional ENA antibodies. And what this shows is that the isolated RNP antibodies, especially in the lower titers, are usually not associated with autoimmune connective tissue disease based on these percentages in the far right-hand column, whereas those that appear in conjunction with additional ENAs or are at higher titers, they are more likely to reflect an underlying autoimmune connective tissue disorder. So just be leery of the isolated RNP, especially at low titers. I don't know why this is, it just is. All right, so that brings us to the end. In summary, ESR and CRP, they are true markers of inflammation, and it's really fun because you can integrate physiology and physics when you're interpreting these results in the clinical setting. For rheumatoid factor, remember the chronic mnemonic? It rhymes, that's kind of cool, because rheumatoid factor is non-specific. It's just an antibody that binds to another antibody, and that can occur in a lot of different settings, whereas anti-CCP is much more specific for rheumatoid arthritis. And then ANA is sensitive but not specific, and it's sensitive for many autoimmune diseases, not just lupus. You'll have to use clinical correlation and test characteristics when you're interpreting the ANA, remembering that sensitivity, specificity, just the clinical gestalt, how does everything sound, treating the patient and not the lab. And then for the ENA, be wary of an isolated RNP antibody, especially if it's a low titer, because it's likely to be a false positive. And here's my list of references. And thank you very much for coming. The additional questions will be posted. And I'm going, if you'd like to do those on your own, and I will now, it looks like we have some questions, so I will let.
All right. Thank you so much, Dr. Zickuhr. That was wonderful. Lots of information, and I think that learners will be using this information for many years to come and sort of, you know, becoming very comfortable with it. I'm listening to a echo here. Is everyone else hearing that echo?
Yes, there is an echo, Dr. Jonas.
Now it's gone, I think. Anyway, I'm not sure why that was. Anyway, I'm joined by Dr. Mohammed from the University of British Columbia, and we're going to be our question askers today. There's quite a number of questions in the Q&A, so I'm going to start with this one. When you talk about describing the sensitivity and specificity of ANA, were you referring to its sensitivity and specificity in the diagnosis of lupus?
So that's a great question. So the data I pulled were actually from all connective tissue diseases. That was the cohort that was selected. It was not specific just to lupus. But that's a really good question, and I think that's why it's always important to look at where these data come from. But that particular chart was from all connective tissue disease.
Okay, and the second part to that question is, given that ANA can be associated with a multitude of diseases like you showed us, what is our role as rheumatologists? So you may get there and say, okay, well, I don't think you have an autoimmune connective tissue disease. I'm going to send you back to your primary care doctor. What is our responsibility? Are we doing the workup for the other things? And how do you do that in your practice?
That's a really good question. So it's like, okay, you don't have lupus, but now what? And so I think what we can offer as rheumatologists is that we have the expertise to listen to a story and to be able to put those puzzle pieces together. And so when I see a patient who's referred for a positive ANA, it's often because they say, oh, my lupus test is positive, I have to have lupus. And so that's number one, like I'm evaluating, do you have lupus? But then I'm asking all of these other questions that are hopefully targeting at all of these other conditions that are associated with a positive ANA. You know, do you have dry eyes or dry mouth? Do you have any rashes? Or did your fingers change colors in the cold? Things like that. And so we have the time and the expertise to be able to do a full multi-systemic evaluation and really listen to the patient's story and see if it matches any of the conditions that are listed on that table. And, you know, I remember my PCP days. from when I was a resident. There's no way that they can do all that in 15 minutes, plus manage the diabetes and the hypertension. And so that's the fun service that we get to provide to our colleagues who refer patients to us, to be able to sit down, do a history, do a physical exam, and hopefully come up with an informed decision about next steps based on that.
All right, Dr. Mohammed, I'm going to turn it over to you to ask the next question.
Yeah, we have a question from James Vandenberg. He has two questions. Let's start off with the first. So he's been told by older rheumatologists that ESR and CRP are less useful in following disease activity in SLE patients. Is this true? And if so, why is it less useful in this population?
That is a great question, James. I love it. And actually, just for time purposes, I had to cut some of this out, and that was one of the topics that fell. But it is covered in the independent knowledge transfer question, so we'll touch on it here. Great question. So in lupus, lupus patients make a ton of antibodies. They make it to everything. So most often, the classic finding that you will see in patients with lupus is that their ESR is elevated and their CRP is maybe a little bit elevated, maybe not so much. But it's like this ESR is just always there because these patients always have antibodies going around, creating rouleau formation and elevating the ESR. It's true that sometimes, different patients every patient is unique. And so ESR and CRP, you have to really look at the individual patient and follow over time to see if fluctuations in those are associated with lupus flares and lupus disease activity. So I'm going to caution and not make a blanket statement for all patients with lupus, but I will say this, that because of this discordance in the ESR and the CRP, what is often helpful is that in lupus patients, when you all of a sudden see a rise in the CRP, and you're looking at the ratio of ESR to CRP, that could sometimes be a clue of an underlying infectious process rather than a flare of lupus. And that's sometimes really hard to tease apart because what symptoms do you get with an infection? Maybe you get some chest pain, maybe you have a fever, and some of these things can definitely overlap with a lupus flare. And that ratio of ESR to CRP can be helpful and help in trying to distinguish between, is it lupus or is it an underlying infection that's causing some of these acute symptoms? So great question. I think you had a second one too, right?
Yeah. Sure. The second one is, do you think that the diagnostic criteria of ANA titers of 1 in 80 leaves behind patients with lower ANA titers who do in fact have SLE?
Yeah, that's also great. I mean, so just based on stats, the answer is yes. And so that's why everybody kind of has a different way of triaging referrals. And so I continue to see patients that have the lower titer ANA because you don't want to miss anyone. And adding that clinical evaluation is really important. The other thing is that I find that in my personal experience, and I have no data right now to back this up, this is just anecdotal, but I find that some of the other conditions like scleroderma or Sjogren or even rheumatoid arthritis, they may have some of the lower titer ANAs rather than the higher ones. And so when I see an ANA that's a little bit lower, then I'm oftentimes I'm thinking more about those other conditions rather than just lupus.
Okay, so I have another question, and this comes from years of experience. Periodically we'll see a patient who has a very high titer ANA or a very high titer rheumatoid factor, and as you mentioned, we're worried in these high titer settings. And you do your very careful HMP, and you got nothing. You got no rheumatic disease, you got no cancer, you got no infection, you got no nothing. And we know from data, old data from military recruits, that oftentimes the antibody titers may be positive before the patient develops disease. What is your approach to following those patients over time? Do you follow them? Do you send them back? What do you do?
That's a great question. So part of it depends on, so this is where shared decision-making comes into place. Because I explain all of that to patients. When you have a really high titer, it's possible that you may develop something in the future. I'm happy to see you every year, every 18 months, just to evaluate. Or these are the symptoms that you can look out for. and call me if you need me. And it's interesting because some patients are like, I don't want to come see you every year. And some are like, I got that, you know, like I'll call you when I need you. And others are, oh yes, no, I will be here once or twice every 12 months and we can talk, and that's fine. So part of it also that may sway me more towards scheduled follow-ups is family history. So if someone has a family history of an underlying autoimmune condition, you know, like that person is just, they're going to develop something at some point. Or if maybe they have like hints of something in their history. So for instance, I have a patient who has a positive ANA and a positive SCL70. She has no GERD, no skin thickening, no Raynaud's. She doesn't have anything, but she did have this weird kind of periodic fever for 6 months. It just randomly disappeared. So she's someone I follow because she's going to develop something at some point. So part of it is, you know, patient preference, as well as you mentioned, Dr. Jonas, just clinical experience over the years and having a feel for, oh yeah, I think that's going to be something in the future. Mm-hmm. Same thing with rheumatoid factor and CCP. I saw a patient this morning. She's got a very high titer CCP, and there's not. I ultrasounded her. Everything. There's nothing. So I continue to follow her because it's a matter of time before she develops RA.
I think for the sake of time, I'll kind of clump the last two questions together. It's from an anonymous attendee. First question is, when you say isolated RNP, do you mean isolated RNP with negative ANA or isolated RNP with a positive ANA? Second part is, how do you usually interpret ribosomal P antibody? Oh,
okay. So the first question is isolated RNP. I'm trying to remember. I think I don't believe this study actually looked at ANA positivity. It just looked at the ENA. And so I can't comment on whether or not an ANA is present. But in my personal practice, if it's a low titer ANA with a low titer isolated RNP, I may do the workup and I'll do the history and the physical, but I don't usually, that's not somebody that I would like follow very closely for the development of an autoimmune disease. And then the question is, how do I interpret the ribosomal RNP? Is that the other question? Okay. So that antibody can be associated with neuropsychiatric lupus. And much like all of the ENA antibodies, I look at it in the clinical context and I let it inform or refute kind of the phenotype of a patient's condition. So I don't necessarily interpret it any differently than any of the others. I incorporate it into the clinical context. There's been some controversy over how useful that antibody is. And I have to say, you know, since I'm at WashU, they don't even report out that antibody any longer. So I haven't been put in this situation in a while because I don't even have the opportunity to interpret it. But it can be associated with NPSLE, and I don't think I've ever seen an isolated one. Has any of the other moderators on the call ever seen an isolated? No, yeah. Usually it's in cahoots with some of the other serology.
I'm not sure it's on the panel. I think you have to order it separately. I've seen people order it on the CSF, but again, I don't think we really understand what it is. And I don't think it's specific for neuropsychiatric disease. It had been looked at as sort of a marker, but you know, it's something that I rarely, if ever, use. I can't even remember. Yeah. Yeah, and we don't really have any more time, but there's one question, and I think it's a good one I want to ask you. Do we have to check an ANA with an ENA, or will an ENA alone suffice in the evaluation of the patient?
That's such a good question. And so guidelines will tell you that the screening test is ANA because it's sensitive, super sensitive, 90% sensitive. And so they'll say, check the ANA first, and if that's positive, move on to the ENA. I sometimes don't do that. Sometimes I'm like, I'm just worried about Sjogren's in this patient. And sometimes I just check the ENA because I just want the SSA and the SSB, and I skip that step. And that's totally against guidelines, but it's what I do every now and then to save kind of like arguing away this 1 to 40 ANA titer. But guidelines will tell you that the ANA is the screening test, and so you should start there before moving on to the ENA.
All right, so the real deal from the clinic. at WashU in St. Louis with Dr. Zickuhr.
I'm blushing now. I shouldn't have told you all.
It's okay. There's no secrets here in rheumatology, right?
That's true.
All right. Well, I just want to thank Dr. Zickuhr for being our speaker this morning and Dr. Mohammed for co-moderating with me. I hope everyone has a great day, and we look forward to seeing you again next week in our next VIP lecture.
Very good. Thanks, everybody. Check out those questions if you're interested. They're posted.